So we gathered information on all patients who had progressed from the Spanish registry, who had been treated with a commercial CAR T-cell product. We identified 217 patients, 2/3 approximately of which received treatment with a curative intent. 1/3 went on to receive palliative or supportive care. Of those 2/3 who received active treatment, we identified 4 main subgroups. That would be our POLA-Benda. We identified some patients with immune checkpoint inhibitors, intensive chemotherapy, and some bispecific antibody trials, mainly with glofitamab, anti-CD20, CD3. We identified some interesting differences in response rates, progression-free survival, and overall survival between the 4 main subgroups. These benefited mainly our POLA-Benda and the bispecific trials. So we found that responses in these 2 subgroups were higher than intensive chemotherapy and immune checkpoint inhibitors. And that was one of the main conclusions of our study. Another important conclusion would be that patients who progressed early, especially in the first 2 months after CAR T-cell infusion, had a dismal outcome in comparison to those patients who progressed later. So I think that is also one of the other main conclusions of the study. And finally, we think that all patients who respond, whether a complete or partial remission to salvage treatment after CAR T-cell progression, should be considered, if eligible, for an allogeneic stem cell transplant, because these patients do have worse outcomes, and PFS and OS is usually short with the treatment, salvage treatments alone. So they should be consolidated with an allogeneic stem cell transplant if that is feasible and accessible to these patients. Yeah, so we haven't had a lot of issues with cardiotoxicity in our CAR T-cell patients. It's true that we did see, and that's actually published in a letter in Hematological Oncology, we identified some patients who experienced a neurotoxicity, had some bradycardia. So whereas their normal heart rate was approximately 70 beats per minute, maybe they went down to like 35 beats per minute and stayed there for a few days while experiencing the neurotoxicity. This did not happen in all patients, just in approximately 5-6 patients who had grade 3 or higher neurotox. We weren't able to identify any reason for this. Laboratory values or pre-existing comorbidities did not seem to explain this. So it does seem related somehow to the neurotox. We don't know the exact mechanism, but we found that this was an interesting finding in these patients and should be taken into account when we're managing these types of toxicities.